Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to yet another primary snippet. So today we are going to discuss about inhaled nitric oxide and prostacyclin. So Maddie, can you please describe the mechanism of action and adverse effects of each of them?
Sure. So we might start with nitric oxide. So the mechanism of action of this is that it is inhaled, obviously. It's rapidly absorbed into the pulmonary circulation, and then it activates guanylate cyclase. There's two versions of this, but the one that it activates is a soluble enzyme in the cytosol. It converts the then GTP into cyclic GMP, which then activates protein kinase G. And this inhibits the IP3-mediated release of calcium, which phosphorylates or inactivates voltage-gated calcium channels, phosphorylates phospholambin, which is something that regulates the calcium pump. And all of this then results in an increased calcium uptake in the sarcoplasmic reticulum. And this results in smooth muscle relaxation and therefore pulmonary vasodilation. And because this is in inhaled regions, so ventilated regions, hopefully this will increase VQ matching. The potential adverse effects of this, one of the main potential ones that we think about is methemoglobinemia. And the reason that this can happen is that nitric oxide reacts with oxyhemoglobin to form methemoglobin and nitrate, and it also reacts with deoxyhemoglobin to form nitrosyl hemoglobin, which is then also converted to methemoglobin on exposure to oxygen. So in increased doses, it can cause methemoglobinemia, which is why we do monitor the methemoglobin levels. The other metabolic pathways, like nitric oxide, can combine with oxygen and water to produce nitrogen dioxide and nitrite, which can interact with oxyhemoglobin to produce methemoglobin and nitrate. And the formation of nitrogen dioxide depends on the nitric oxide concentration, the FI2 you're giving, and the amount of time they're exposed to each other. So the nitrogen dioxide with higher lengths of times or duration of times of exposure or higher FiO2 or higher parts per million of the inhaled nitric oxide, it can result in increased levels of nitrogen dioxide, which can cause a lot of adverse effects, including worsening ARDS. It can cause irritation to the lungs, bronchiolitis, pneumonitis, and airway injury. The other potential adverse effects are there's found to be an increased risk of renal impairment. There's also the risk of platelet inhibition, and there is a risk of rebound pulmonary hypertension and hypoxia when you abruptly withdraw the nitric oxide. So that's why we do wean it. As well as you can get increased blood flow to left heart. So there is the theoretical risk that you could get things like APO if there is existing LV dysfunction. Then coming to inhaled prostacyclin, this is also an inhaled pulmonary vasodilator, but it has a different pathway to achieve that. So it's a derivative of arachidonic acid, and it activates G protein-coupled receptors on platelets and vascular endothelial cells, which activates adenylate cyclase and increases intracellular cyclic AMP. This inhibits further platelet activation as well as activates protein kinase A, which phosphorylates and inhibits myosin light chain kinase and causes smooth muscle relaxation and vasodilatation. So one acts mainly through these G-coupled receptor or cyclic GTP, and one acts through cyclic AMP, but the end result is smooth muscle relaxation and that therefore causing vasodilatation. In terms of adverse effects, there is the risk of bleeding because it does inhibit some platelet function. And there is the major sort of adverse effects that are seen are systemic. Like it can result in some systemic vasodilatation, so flushing, headache, hypotension, and tachycardia. But this is obviously lessened by using an inhaled route. It can also cause bronchospasm. And there's a diluent that's part of it called glycine, which can block expiratory filters and increase the resistance. It can also inhibit gastric acid secretion and decrease gastric emptying.
Thanks, Maddie. So with regards to inhaled nitric oxide, clinical indications include often predominantly persistent pulmonary hypertension in the setting of either right ventricular pathologies or heart transplant or lung transplants. Usually it is clinically used in setting of ARDS in some of the centers, but having said that, there is not much evidence for its benefit.
Yeah, and it seems very institutional dependent. So in my current institution, we use inhaled prostacyclin, don't really use nitric, but I know that in some of the other hospitals, they tend to use nitric more.
Thanks, Maddie. So that's the end of our today's podcast. We'll be back with another snippet in a week's time. Till then, Goodbye and have a nice time.
Thanks for listening. See you next time.